So next is v24 liver laceration. A 65-year-old male fell off a ladder and is brought to the ED. On examination, he is alert, oriented, GCS 15, but tachycardic and hypotensive with a large bruise over the right lower chest wall. He is very tender over his right upper quadrant. When you arrive, he has been resuscitated and his blood pressure has improved. A chest X-ray and pelvis X-ray are normal, and a fast scan shows some free fluid in the hepatorenal angle. How will you manage this patient? So this patient should be approached by ATLS principles. Firstly, I would check the initial resuscitation is complete. A, B, C spine fixation, oxygen analgesia, two large bore cannulas, group and save, arterial blood gas, clotting studies. It is important to clarify how much resuscitation he has given and whether he is a responder or transient responder. This guides planning and allows prediction of the future. And I would review any notes and ask for the catheter to be placed, and I will ask for ample history from the paramedics about how far he has fallen and was there any consciousness or trauma, loss of consciousness or trauma to head and neck at the scene. Also carry out a secondary survey to look for other injuries. With the bruising over the right side of the chest, normal X-ray initial representation, I would suspect a liver injury. Because he has responded to resuscitation and is maintaining his blood pressure, I would ask for an urgent CT scan with IV contrast. However, although he is a transient responder, I will want to keep a close eye on his observation with a low threshold for operating effective rates. Why would you not take patient to theater immediately? Blood liver patients who are hemodynamic stable, sometimes they can settle with the conservative treatment. He has responded to resuscitation and his blood pressure has been normalized, and there's no longer requirement of laparotomy and hemostasis. A CT scan will grade the degree of liver trauma and will also rule out the other injuries, and small lacerations can be successfully managed. CT scan will identify other injuries as well. How liver injuries are classified: American Association of Surgery for Trauma has classified the liver trauma into the 6 grades. And grade 1, less than 1 laceration, less than 10% hematoma under the capsule. Grade 2, 1 to 3 laceration and 10 to 50% hematoma. And grade 3 is equal to more than 3 laceration and more than 50% of hematoma. And grade 4 is some hepatic dissociation, and grade 5 and 6 correspond to major vascular injuries and hepatic avulsion and associated with high mortality. His CT scan shows a grade 3 liver laceration and no other internal injuries. How will you manage him? So he will require I will keep him in ITU, close monitoring, and alert the radiologist, theatre staff, anesthetist, ITU specialist, and group and safe done. And he needs serial monitoring and consider re-imaging. So during the transfer to HDU, the patient becomes cold, clammy, and hypotensive. What do you do? So this patient should be decompensated and he should be now do immediate trauma laparotomy. The patient should go straight to emergency theatre, anesthetic room. We should do WHO checklist, and following the principles of damage control surgery, laparotomy should be done. It should be damage control resuscitation. So I will open the abdomen from Ziffy to the pubis, suck out the blood and the clots, put 4 packs, let the anesthetist optimize his physiology. Once they are ready, then we can further take the packs from the normal area first and then see where the bleeding is coming. If only source of bleeding is coming from the liver, I would repack the liver using a sandwich technique, placing packs behind, under, over the liver, and then either close the skin or form a laparoscopy dressing. Topical hemostatic agents can also be given. If the patient needs specialist care, then liaise with the major trauma center or liver unit. Are you aware of any techniques that can be used to control the bleeding from a damaged liver? Pringles maneuver and supraciliac aortic clamps, venovenous bypass, and consider for topical hemostatic agents. What are your options if the patient remains hypotensive and your initial maneuvers are not containing the bleed? So more aggressive bleeding may require additional maneuvers, in addition to hepatic manual compression and hepatic packing, ligation of the vessel in the wound, hepatic debridement, balloon tamponade, and shunting procedures. The Pringle maneuver can be performed for up to 1 hour to control the bleeding. Temporarily, abdominal closure can be safely obtained in all those patients when the risk of developing abdominal compartment syndrome or relocal laparotomy, where resection is required for hemostasis. Non-anatomic resection is safer and easier. Portal vein injury should be repaired primarily. If we tie the portal vein, the liver will be liver necrosis and massive bowel edema will happen. If bleeding persists from behind the liver, a retrohepatic caval or hepatic vein injury mm, could be present. Firstly, tamponade with hepatic packing should be considered. Other options include direct repair with and lobar resection. What are the potential delayed complication? Blunt hepatic trauma complication occurring more than 10% of the patients after high grade injury. Although routine imaging is not necessary, clinical indications, abdominal pain, fever, jaundice, a drop in hemoglobin indicate a follow-up CT scan. Complications include the biloma, necrosis, complicated abscess formation, abscess and melanoma can be treated by drainage, and some biliary complications requiring the ERCP. Most rebleeding are secondary to hemorrhage and pseudoaneurysm, hemophilia, and compartment syndrome. In general, patients who have been well may go back to normal activity by 3 to 4 months, as follow-up studies generally show that liver should have healed by then.